request to start his speech.
Thank you so much, and I thank Vidikon for giving me this opportunity, especially Amitabh and Namaste. My topic is to deal with some controversies related to a very common disease, subclinical hypothyroidism. I will try to see whether we can arrive at some consensus in the various issues. So this is the agenda I am going to go through today. Let us start with the first one, that is the journey of subclinical hypothyroidism. So it has been evolving since last 5 decades, and it was initially coined in 1973. And in 1976, Nielsen had made a very interesting observation, a philosophical observation. The subclinical hypothyroidism is an example of impact of technology on the concept of disease. That means it depends on how you are measuring your THS, and that's how you arrive at a definition of subclinical hypothyroidism. Because it's only THS which changes, nothing else changes. There will be no specific clinical criteria to diagnose subclinical hypothyroidism. I'll come to that. So the THS assays have been changing. You can see here. Initially, the lowest limit for detection was 5, and now we have 0.01 CLI, chemiluminescence assays, very sensitive and with high precision. And because of this lowest detection limit, we now have a lot of people who we can actually exactly identify what is the THS level, and that leads to a diagnosis of subclinical hypothyroidism. So what is a THS reference range? Again, for any population reference range, you have this distribution curve. It's called Gaussian distribution, where the mean value is in the middle, and you have a spreading out like a inverted bell. Okay, and the right side and the left side, the extreme cases are actually taken as the 97th centile on the right side and the 3rd centile or 2.5 centile on the left side. Within that, we consider them as normal. But for THS, there are some interesting observations. For example, there will be some euthyroid outliers. That means some people may have high THS like 6 or 7, but they can actually be euthyroid. And there could be some occult autoimmune thyroid disease where your THS could be absolutely normal, but they may have autoimmune thyroid disease going on. So this is somewhat fallacious, and that's why it's very important, and we have to be very careful in actually making a diagnosis of subclinical hypothyroidism. This is actually a big NAHANES, and hence so-called study where they had done a survey of more than 13,000 patients, where they found that the mean value for their population who are negative for thyroid antibodies, who didn't have any family history of diabetes, and who didn't have any goiter. So all confounders eliminated, the mean value was around 1.12. So 2.5 to 97 percentile was 0.45 to 4.12, and mean is 1.4. So that's how we are now having the assays. So why you call this range as a normal? Because this is because of these studies, but in this particular study. There's few other studies, for example, these Korean studies had a mean value of 1.82 and median value of 1.62. And another study from Swedish population, it was a little bit skewed towards left, the mean value was around 1.2. We did a study, so-called Guwahati Thyroid Epidemiological Study. Ours was a little bit shifted to the right. The mean value for male was 2.1 and for female it was 2.1203. It's a little bit similar. So we are slightly on the right side of the mean value what we have found in the Western literature. So what is this definition of subclinical hypothyroidism? What is the epidemiology? So it is characterized by serum THS above the upper reference limit in combination with normal free thyroxine. We all consider 4.2 or 4.5 as the upper reference limit. But your free thyroxine or total thyroxine has to be normal. Generally, you can diagnose this as subclinical hypothyroidism. In case your THS is coming above 10, probably it is dangerous to diagnose that patient as subclinical, because that patient may be actually harboring a clinical thyroid disease. Of course, if your repeated T4 levels are normal, that patient still can be considered as subclinical hypothyroidism. This designation is only applicable. So what are the confounders? When thyroid function has been stable for weeks or more, recent fluctuation may give a fallacious result. The hypothalamo-pituitary thyroid axis is absolutely normal, and there is no recent or ongoing severe illness, because we all know there is something called non-thyroid illness where THS and T4 levels, either T3 levels can go away. So we have to wait for the recovery from the illness then repeat the test after 4 to 6 weeks and arrive at this definition. So what is the prevalence of subclinical hypothyroidism? Actually, it's very interesting. Subclinical hypothyroidism, if you take the cutoff of 4.2, it is higher in case of younger population, lower in case of younger population. For older population, it is higher. So THS rises according to the age. Every decade there is a rise in THS. So if you consider 5 or 6 as abnormal for a young person at the age of 35, that may not be normal, that may be absolutely normal for an 80-year-old person, and this has got huge implication on your treatment, because you should not try to treat elderly population with subtle rise in THS that might cause some danger. So the epidemiology wise in India we have in previous studies like taking the cutoff of 5.5, the 7 city studies found that the prevalence is somewhere around 7 to 9. Kolkata it was 11, so mean was around 7 to 9. Baruah et al, they took a cutoff of 4.2, and in our study we took a cutoff of 4.2. There we found that the prevalence is more. In our case it was almost 1/4 of the population was having high TSH, so you can consider them as subclinical hypothyroidism. Whether you treat them or not, that is a different question, but epidemiologically they had that problem, and Baruah et al also find 1 out of 5 Indian population they have subclinical hypothyroidism. Any clinical feature, do the clinical features help? It is very interesting again. There are many symptoms of subclinical hypothyroidism which are present in normal population. So you cannot actually, based on clinical features or any clinical scoring system, you cannot actually differentiate whether the patient is having subclinical hypothyroidism or not, because there is a huge overlap between overt hypothyroidism, subclinical hypothyroidism and euthyroid population. So clinical features are not that much helpful. They are helpful only secondarily, not primarily. What are the controversies regarding the treatment of subclinical hypothyroidism? Whether to treat them, because we said it's a subclinical disease. So any subclinical disease can only be treated if there is a future morbidity associated with that. So should we treat them or not? So what are the arguments in favor of treatment? So one argument would be you can prevent overt hypothyroidism, or you can actually have a potential impact if you bring down the THS below 10, and especially in conditions like dyslipidemia, mood disorders, and reproductive age female, infertility, pregnancy, etc. So there are certain conditions where probably we are proactive in treatment, but mostly not treating the patient may not cause any huge harm to the patient, but you have to be on alert, because the argument against treatment is a cost, danger of over-treatment, and in many patients there will be reversal to normal, and data regarding improvement in various clinical conditions, mood disorders, etc. are very vague. They are not very solid. But still I will provide you some clinical trial data so that you can derive an opinion whether to treat or not. So what about the progress of mild thyroid failure or subclinical hypothyroidism? So initially you can see the TSH keeps on rising. But when the THS is rising above normal, your T4, T3 could still be normal. Then the T4 starts falling and T3 falls the last thing. It's the last thing to happen. So this is how a normal hypothyroid disorder will progress. And this will take years for a whole population of patients having subclinical hypothyroidism to have overt hypothyroidism. Many of them will not become, because they will have a reversal. And there are some interesting data regarding reversal. You know, if you do not have antibody positivity, there is a chance that a huge number of patients could actually reverse from subclinical hypothyroid state that is less than 10 or more than 4.5 or 5 to normalcy. So that's why their argument is also against treating all of them. But if you are antibody positive, there is a more and more chance of progressing into overt disorder, and that's how it is actually. Every year there will be a progression of 5% per year if there is antibody positivity. Okay, but if there is antibody negativity also, there could be a chance of 2 to 2.5% progress. So antibody itself again doesn't tell you in a very convincing term that yes, if there is antibody positivity, I have got hold of a person who will definitely become hypothyroid and must treat it. But that is only one thing which helps you to decide on the treatment. So antibody testing is important in subclinical hypothyroidism. So what is the recommendation from American Thyroid Association is that it should be considered. They're not saying that must be considered. And if anti-thyroid antibodies are positive, hypothyroidism occurs at 4.3% per year versus 2.6% per year when anti-thyroid antibodies are negative. So the presence of positive thyroid antibody may or may not influence the decision to treat. Again, there is a controversy here. We have not yet arrived at a conclusive decision regarding antibody testing and the decision thereof. What about subclinical hypothyroidism and cardiovascular outcome? So there has been various studies which have shown that if there is subclinical hypothyroidism, especially around the range of 7, 8, 9, there will be increased cardiac issues. So I'll try to show you this beautiful diagram where if you are euthyroid and if you have subclinical hypothyroidism in the range of less than 4, the hazard ratio is not significantly different, you can see here. But if your THS rises beyond 7 or reaches around 10, the hazard ratio is very significant. That's why we can take a cutoff of either 10, or if you are very strict in this, we can take a cutoff of 7.5 to treat all patients of subclinical hypothyroid patients, especially to reduce the cardiovascular mortality, because this is another study where age is also a big confounder. The influence of age on the relationship between subclinical hypothyroidism and ischemic heart disease is very interesting. This meta-analysis shows that patients who are less than 65 years, they have a higher or significant association with ischemic heart disease. But patients who are more than 65 years, the association is weak. It's in the line of unity. That means either whether you have high THS or normal THS, the cardiovascular risks are equal. But younger population risks are more. That's why maybe this is one pointer where you can take age as a cutoff for treating subclinical hypothyroid patient. And this is a comparison of various studies. The weekend studies, atomic home survivors, and all these studies are conducted on patients who are less than 70 years. And the health aging study was 70 to 80 years. And Legends 85 plus study conducted over the years of 85 years. You can see very beautifully depicted here. There is a positive association with ischemic heart disease in younger population and a negative association in elderly population. That's why you should not attempt to treat elderly population of subclinical hypertension, because you are actually increasing the risk of cardiovascular disease. But that is not same. It is not same with the population who are younger, where treating will help. So the same thing has been repeated here in 70 plus cases. There is no significant association between treating with levothyroxine and subclinical hypertension and reduction of cardiovascular events. But there was a significant association when the patients were included patients were less than 70. So 65 to 70 could be a cutoff where you can either be aggressive or be not aggressive at all. So that's a recommendation. In patients whose serum THS levels exceed 10, there are increased risk for heart failure and cardiovascular mortality should be considered for treatment with levothyroxine. This is the recommendation from ATA. But for some people, even 7.5 could be a cutoff, especially if the patient is less than 65. Probably treating that patient will help. What about the pregnancy? It's a very interesting topic. The association of subclinical hypothyroidism and pregnancy is always controversial, and it is defined as a normal serum free T4 level with elevated THS but below 10. If it is above 10, ATA says that this is overt hypothyroidism of pregnancy. It is somewhat different from in the normal population, non-pregnant population. Okay, so there are a lot of unanswered questions, and we wrote this article long back regarding this unanswered questions. The questions which come to clinicians' mind: should every antenatal patient be screened during first trimester? Should every antenatal patient with subclinical hypothyroidism with THS above 2.5 be treated? And should every patient with normal THS during first trimester be screened again during subsequent trimester? I'll try to give answers to it. These are the THS cutoff for definition. For population where there is no study, highest cutoff could be taken as 4, but usually it is 2.5 in the first trimester and 3 in the second and third trimester. As for all guidelines, even IPS guidelines also say that 2.5 and 3 are the cutoff for normal pregnancy. Above 3, we have to consider that patient as having subclinical hypothyroidism. And actually, whether the maternal hypothyroidism impacts fetal outcome, there has not been any RCT because we cannot conduct any RCT in pregnant babies. Okay. But what is important is to understand that if there is antibody positivity, there is definitely a gap with a lot of problem. So subclinical hypothyroidism association with autoimmunity, that's a dangerous thing. We must treat them. But without autoantibody positivity, maybe 2.5 to 4.5 range, you may not treat also. You may just observe. But above 4.5, that is your discretion. You have to play it safe. So what is, we should screen everyone. Again, Indian Thyroid Society says that it should be universal. European Thyroid Association says that not universal. American Thyroid Association is equivocal. They say that you may, they are not neither recommending nor rejecting the proposal that there should be all pregnant women should be screened. This is the list of high risk category. I will not go into details of these are the patients. This is beyond universal screening. This is high risk screening. These patients must be screened for thyroid disorder during pregnancy. And moreover, the core target for THS when you are treating subclinical hypothyroidism is that your THS should be the lower half of the trimester specific reference rate. That means if your trimester specific reference rate is 3, you try to be less than 1.5 while treating. That is your target. Not on the upper side, like 1.7 or 2.1 like that. You should be 1.2 or 1, maybe 0.5 or so. And what is the monitoring frequency? People who are at risk of hypothyroidism or already having hypothyroidism of subclinical category or overt category, whether treated or untreated, should be monitored with a serum pHs every 4 weeks till mid-gestation, then at least once near 30 weeks gestation. This is important. Initially, first trimester you must be very frequent in your screening. And moreover, there is increase in demand for levothyroxine. So your levothyroxine dose must be increased, and you monitor and try to keep the pHs below the range by monitoring every 4 weeks. So whenever your patient tells you that I am pregnant, probably it is a time when you increase the dose without even testing pHs. Increase the dose by 15 to 20%, and then that you can do simply by asking the patient to take 2 tablets extra every week, same dose. That will increase it by 15 to 25%. So there is at least 50% increase in thyroxine requirement during pregnancy that has to remember. So there are various other issues, general aspects, but there are some important messages. Is that this is last 2 slides. So we must understand that normally a daily dose of 25 to 75 micrograms should be considered for subclinical hypothyroidism. So your upper target would be 1.2 microgram per kilo body weight. For overt hypothyroidism, the target is usually 1.5 to 2 microgram per kilo body weight. We must not attempt to give iodine supplementation in patients who are coming from iodine sufficient areas, and there are a lot of medications where you use selenium, thinking that selenium could actually revive thyroid function, but there has not been any evidence, and ATS strongly says that do not use selenium for thyroid disorders. And whether cognitive disorders can be improved by giving thyroxine, there has not been any strong evidence, so there has been no consensus on that, but it's again clinician's discussion. Many times the psychiatrist and physician must discuss together, and for the benefit of patient, you may try to low dose, not endangering the patient's life. Don't use a very high dose. So what is the conclusion and the take-home point? If your THS is high with normal 3T4 3T3, that is subclinical hypothyroidism, so you should repeat it in 4 to 6 weeks, because by not treating the patient immediately, you are not killing the patient. But by treating the patient, you might actually endanger or increase the comorbid conditions. So repeat it, but if possible, do an anti-TPO test, because at the very beginning you may actually come to a conclusion. So if it is TPO positive, then T4 treatment is mandatory. If the THS is more than 10, again without anti-TPO positivity also T4 treatment is mandatory. If TPO is negative and THS is less than 10 and patient has got no symptoms or no other risk factors like this, then you should repeat it after 6 months. If THS is less than 10, but patient has got certain symptoms like goiter, pregnancy, patient has got other autoimmune diseases, especially type 1 diabetes, celiac disease, etc., and other autoimmune endocrine disorders, or cardiovascular risk, and patient is less than 65 years, patient has got ovulatory dysfunction, infertility. Of course, you should drink levothyroxine, keep the dose low, like 25 to 75, to achieve your DHS, personalized DHS target for that patient. Thank you very much. I hope I could